Good evening, sir. I am presenting the case history of patient Kalavati, 43 years old female, wife of Sundar, resident of Salimpur, Delhi, and housewife by occupation. The chief complaints are the patient is having breathlessness since 15 years, on and off cough since 12 years, and on and off palpitations since 10 years.
Okay, go ahead.
History of present illness. Patient was apparently asymptomatic 15 years back when she started having shortness of breath on exertion, which was insidious in onset and gradually progressive. Initially, she was able to take 2 to 3 flights of stairs, and then after 3 to 4 years, she started getting breathlessness on taking 1 to 2 flights of stairs. 5 years after that, she started getting breathless even at rest intermittently. Breathlessness improves on taking rest and on medication, which increases the urine output. Currently, she gets breathlessness on walking 15 to 20 steps. From last 3 4 days, she is breathless even at rest, for which she has to get admitted in our hospital.
Okay. Now, what is the according to New York Heart Association classification? What is the level of breathlessness she is having?
So currently she is breathlessness even at rest. So currently she is NYHA 4.
Okay. Can you define class 1 to class 4? What is class 1, class 2, class 3, class 4?
Class 1 is no limitation of physical activity. Class 1 is by doing ordinary physical activity, she is getting mild breathlessness. Class 2 is even on less than ordinary activity, she is breathless. And class 4 is she is breathless even at rest.
Okay. I think you have to be a little more descriptive. Class 1 is a patient who has got a heart disease. That's the way you have to define it. Class 1 is a patient who has got a heart disease, who is asymptomatic on normal routine activities. Unaccustomed exercise may or may not precipitate symptoms. That is not usually included in the definition. And the symptoms considered are, what are the symptoms considered in the New York Heart Association classification of symptoms?
Dyspnea and palpitations.
Anything else?
Chest pain.
Cardiac pain. Yes, anything else? What are the symptoms considered in the New York Heart Association classification of symptoms? Any other student who would like to tell me what are there are 4 symptoms which are considered. What are those?
Syncope.
So fatigue, dyspnea, palpitations.
What? Breathlessness. Vomiting.
Oh, yeah.
No, not vomiting. What are the symptoms considered for classifying the cardiac symptom according to New York Heart Association classification?
Fatigue, dyspnea, palpitations, and chest pain.
Fatigue, it is dyspnea, breathlessness, palpitation, cardiac pain, and fatigue. One of the 4 is no. So class 1 is a patient who is having heart disease, who is asymptomatic on normal routine activities. But he may or may not have symptoms on unaccustomed exercise, and the symptoms considered are breathlessness, palpitation, cardiac pain, or fatigue. One of the 4 is no. Class 2 is a patient who is having mild symptoms. Normal routine activity precipitates symptoms. So my patient is mildly symptomatic. Class 3 is a patient who has got moderate symptoms. The patient is comfortable at rest, but less than normal routine activity precipitates symptoms. And class 4 is a patient who is severely symptomatic, who can be symptomatic even at rest or cannot perform any duty without developing symptoms. So you should be very clear about the definition of New York Heart Association classification. These are the class 1, class 2, class 3, class 4. So the 4 symptoms which are considered are, to repeat once again, it is breathlessness, cardiac pain, palpitation, or fatigue. One of the 4 is enough. And I already defined class 1, class 2, class 3, class 4. Obviously, this patient is symptomatic even at rest, so she is Class 4 symptomatic. Okay, go ahead.
She also have history of episodes of breathlessness at night 2 to 3 hours after sleeping, due to which she has to wake up and sit upright with legs hanging and take fast and deep breaths, after which it gets relieved and she is able to sleep again.
What is that symptom due to? What is that symptom? To give it a scientific term, suggestive of?
Paroxysmal nocturnal dyspnea.
Yeah, the paroxysmal nocturnal dyspnea. What are the mechanisms of paroxysmal nocturnal dyspnea? Why does it happen after 1 to 2 hours?
Uh, there are multiple mechanisms. One is after 1 to 2 hours of sleeping, there is increase in the venous return, leading to more fluid in the pulmonary interstitium and alveoli. Also, 2 hours after sleeping, there is REM sleep, which leads
No,
to
no, no,
more.
no, no. Your understanding is not correct. No, that's not enough. See, when you have to describe it step by step. There is a fluid reabsorption from the, especially from the lower limb
Pulmonary.
interstitium. Interstitium. What is the reason?
Uh, One is after lying down, there is increased venous return,
Why there is
and
increased
another.
venous return? No. Why there is increased venous return? Reason. What is the hemodynamic change which actually brings out increase in the venous return?
There is a decreased effect of the gravity once the patient lies down. So this it leads to increased venous return and increased
No.
pressure.
That's not enough. No. See, when the patient lies down, what is the main hemodynamic change which helps in the increase in the venous return? That's the question. Any one of you? What is the, when the patient stands up or when the patient lies down, the force of gravity is removed and hydrostatic pressure comes down. In the vessels, the hydrostatic pressure comes down, which results in a reabsorption of fluid from the interstitium into the vascular space. Then what happens? It is
There
returned to
is
the,
venous return to the right side of the heart increase.
yes. Then what happens?
Then there would be more blood in the pulmonary circulation,
Why?
because the more blood that comes from the whole of the body to the right side of the heart goes into the pulmonary artery and then into the pulmonary capillaries, which
Now,
would
you
leak
have to
into.
make one more statement there. If the patient is having a relatively normal or normal right sided function, the extra volume of blood which comes to the right side is pumped onto the pulmonary circulation and to the left side. It's very important that in a patient when a patient is having paroxysmal nocturnal dyspnea, and after 1 or 2 months, the paroxysmal nocturnal dyspnea disappears. What are your interpretations?
If suppose patient develops pulmonary artery hypertension, that is there would be second stenosis, we can say, before so there would be decrease in the symptoms and decrease in the LA pressure as well.
With the pulmonary hypertension, how can there be a decrease in the LA pressure? What is the mechanism?
There would be since there is pulmonary arterial hypertension, less blood would go from the RV to LA, leading to
Yeah,
decrease in the.
that's the most important point. So that will result in some degree of RV right side dysfunction. So if the patient is developing a right sided dysfunction, then paroxysmal nocturnal dyspnea can disappear. So if the patient, so for paroxysmal nocturnal dyspnea, there should be a relatively normal or normally functioning right ventricle, which can receive the blood and pump to the left side of the heart. That's one reason. Second, obviously, if the patient's left side functions have improved, that can result in less of paroxysmal nocturnal dyspnea. So in the description of paroxysmal nocturnal dyspnea, you have to mention 2-3 points. One, reabsorption of fluid. It comes to the right side of the heart, and the right side is relatively normal or normal. The blood can be pumped to the left side of the heart, and if it is dysfunctional, that can result in pulmonary congestion and paroxysmal nocturnal dyspnea. Okay. Now, what are the mechanisms? What are the other mechanisms?
Other mechanism can be when 2 hours after sleep REM sleep comes up, then it leads to increased sympathetic activation, which further leads to tachycardia and decreased flow of blood from LA to LV, leading to PX, paroxysmal nocturnal dyspnea.
If there is tachycardia, why should there be less amount flowing by left atrium to left ventricle?
Because when tachycardia occurs, the duration of the systole decreases.
Okay.
So
And
the
the tachycardia occurs, duration of systole decreases.
duration of diastole decreases. Sorry.
Yes.
So, so
So,
the ventricular filling decreases.
but when there is a increase in the heart rate, what happens to the cardiac output?
Uh, it increases.
Increases. So, if there is an increase in the cardiac output, why should the patient develop paroxysmal? What you can say, that obviously, I agree with you that more often this is more relevant in a patient who has got ischemia. When there is an increase in heart rate, what happens to myocardial oxygen demand?
It increases.
It increases. And so the patient can develop some degree of LV dysfunction, especially if patient is having an ischemic problem, and that can result in paroxysmal nocturnal dyspnea. So that is another mechanism. Okay, third mechanism. You say there are multiple mechanisms. Is there any other mechanism, or these are the only two mechanisms?
These are only two.
Anybody else who would like to say any other mechanism for paroxysmal nocturnal dyspnea? Sleep, is it a parasympathetic function or a sympathetic function?
Sleep is a parasympathetic function, but
Yes.
when REM sleep comes up, it increases sympathetic firing.
One second, please wait. Sleep, is it a parasympathetic function or a sympathetic function?
Sleep is a parasympathetic function.
Yes. When there is a parasympathetic overactivity, what happens to the failing heart? How is what are the mechanisms by which failing heart maintains the cardiac output?
By increasing the heart rate, by increasing the contractility,
Yes,
and by increasing peripheral vascular
it
resistance.
increases the heart rate. Okay, it increases the heart rate, thereby increasing the cardiac output. 1, 2.
Increasing the contractility of the heart.
Yes, how can it increase the contractility?
Uh, One by sympathetic stimulation.
Yes, by sympathetic stimulation. When there is sympathetic stimulation, there is an increase in the contractility, thereby cardiac function can improve. Third mechanism?
By increasing the peripheral vascular resistance.
Yeah, by decreasing the peripheral vascular resistance. And fourth mechanism? By increasing the venous return. The preload, increasing the preload by increasing the venous return, decreasing the three things can increase in three things can increase the cardiac output. They are increase in the preload, increase in the venous return, 2, increase in the heart rate, 3, increase in the contractility. And 1 decrease can increase the cardiac output, that is decrease in the peripheral resistance. So these 4 mechanisms. So you yourself said that the contractility is increased by sympathetic activity. So at night, when the patient sleeps and sympathetic activity comes down, and if there is a more parasympathetic activity, what can happen?
It can also precipitate
Yes,
PND.
the contractility can come down, and the cardiac function can be slightly depressed. And in a person who already has got some degree of LV dysfunction, the decrease in the or increase in the parasympathetic activity and decrease in the sympathetic activity can tilt the balance, and the patient can go for paroxysmal nocturnal dyspnea. And of course, the fourth one is not very relevant, but patients who are having ascites or patient having there may be difficulty. The diaphragmatic movement may be interfered. So when the patient lies down, the diaphragm moves up, and the diaphragmatic movement may be interfered when the patient lies down. While when the patient is standing up, the gravity helps in the diaphragmatic movement. That also can partly contribute to the symptom of dyspnea at night. So there are 4 mechanisms. One, in the fluid reabsorption leading to increase in the fluid, the increase in the venous return to right side of the heart, and that result in pumping of the blood from right side to the left side and pulmonary congestion. 2, as you have already mentioned, when there is an increase in the sympathetic activity during rapid eye movement, that can also result in the symptom of paroxysmal nocturnal dyspnea. And third, the sleep is a parasympathetic function, and when the sympathetic function comes down, a failing myocardium can develop further malfunction, and that can result in paroxysmal nocturnal dyspnea. And finally, you can also mention the diaphragmatic movement may be less favored when the patient is lying down, and that can also contribute to symptom of dyspnea at night. So, but the most important, of course, is the fluid shift. Okay, right. So this patient is having paroxysmal nocturnal dyspnea. So,
Sir, I have a question.
Yeah.
Sir, all these explain why the patient is having dyspnea on lying down, but why is it called paroxysmal nocturnal dyspnea? Why does the patient have it only at night and not during daytime sleepings or such, lying down during the daytime?
No, see, the sleep, when the patient is sleeping, lying down during the daytime, they can definitely have breathlessness, but very often the sympathetic parasympathetic activity may not be that much relevant during the daytime sleep. That may be one of the reasons. And second problem is that patients who are standing and active during the daytime, then only there can be fluid accumulation in the lower limbs. See, why does there is an accumulation of fluid in the interstitium of the lower limbs? Because of the higher hydrostatic pressure. If the patient is lying down during the daytime, then there is no fluid shift there. Fluid shift can happen only when there is a fluid accumulation in the lower limb, which can happen only in a person who is sitting or standing during the daytime and goes to bed at night when there is a decrease in the vascular, the hydrostatic pressure, which will result in the fluid shift from the interstitium to the intravascular space, and there can be a paroxysmal nocturnal dyspnea. So patient who is regularly lying down during the daytime, and even if the patient sleeps, there won't be any dyspnea at all, because there is no fluid shift there. So for the fluid shift to happen during the daytime, the patient should be upright, standing or sitting, and then go to bed at night, and then only there can be a fluid shift. So one more question I want to ask you. Paroxysmal nocturnal dyspnea usually occurs only once. When the patient, you have already said, the patient goes to bed and sleeps well. Why it is so? What is the reason?
One reason might be that now the hydrostatic pressure decreases because the fluid from the interstitium of the lower limb goes into the circulation. Second reason might be that when the patient sleeps again, the another cycle of REM cycle would take around 3 more hours. So it would.
No. The most important mechanism is the fluid shift.
Yes.
So how will you explain that most of the times paroxysmal nocturnal dyspnea occurs only after 1 to 2 hours after going to sleep, and the patient then sits up for some time, the patient gets a relief, the patient goes to bed again, and there is no more paroxysmal nocturnal dyspnea. So yes, I want to know what is your explanation that this is only one episode and there is no more paroxysmal nocturnal dyspnea.
The reason being that when the patient wakes up and sits for some time, and also the fluid that was there in the lower limb, which shifts into the circulation, is now no more into the interstitium. So there is no more fluid in the interstitium to shift in the vascular system.
That's one point. One point. So that fluid which is supposed to get into the intravascular space already has shifted, and there is practically very little or no more fluid to be shifted. There may be some more fluid, but not very significant amount of fluid. One point. Second point. Anybody? Another, yes. Another reason thought about is that these patients, when they sit up with paroxysmal nocturnal dyspnea, very often they become breathless, they sweat also, because there's a significant sympathetic activity that results in sweating, and because through the sweat they can lose some fluid, and this also can contribute to the absence of any more paroxysmal nocturnal, any more dyspnea at night. So two mechanisms. Once we have already mentioned that the fluid which has to shift from interstitium to the intravascular space already has shifted, so there is no more fluid shift. Two, during the episode of paroxysmal nocturnal dyspnea, the patients can have significant sweating, and that can result in some degree of loss of fluid, and that also can improve or rather it can bring down the vascular volume, and that can result in no more episodes of paroxysmal nocturnal dyspnea. So usually paroxysmal nocturnal dyspnea occurs 1 to 2 hours after sleep. Then the patient sits up for some time, and or may stand up and gets a relief and goes to bed, and there is no more episodes of paroxysmal nocturnal dyspnea. The reason is two. One, the fluid shift has already taken place. 2, this patient sweat and thereby losing some amount of fluid through the sweat, and that also can reduce the intravascular volume. Okay, right. Yes, go ahead.
Breathlessness increases on lying down, so she has to sleep with two pillows. Breathlessness decreases on sitting upright with legs hanging. So it means orthopnea is also present.
Yes, orthopnea. Yes. Which symptom is more important, orthopnea or paroxysmal nocturnal dyspnea?
Orthopnea represents more severe disease, while
Yeah.
paroxysmal nocturnal dyspnea presents milder form of disease.
Oh, you cannot use the word milder form. It also indicates paroxysmal nocturnal dyspnea. Sometimes patients can die also. They progressively go into pulmonary edema and they may die. So you cannot say it's a milder symptom, but orthopnea is considered as, if you look at the grade of symptom, orthopnea is considered as a more severe form of dyspnea, breathlessness, than paroxysmal nocturnal dyspnea. Here, patient is not able to lie down at all. While paroxysmal nocturnal dyspnea, patient can lie down, then there is a reabsorption of fluid from the interstitium, and then only develops paroxysmal nocturnal dyspnea. So in a patient with orthopnea, the patient cannot lie down at all. But as far as the heart disease is concerned, do you would like to differentiate between these two? For you, which is more important?
Uh, if we detect the patient in the PND stage only, then it is better for the patient for early diagnosis and treatment.
Paroxysmal nocturnal dyspnea is an unequivocal cardiac symptom. That's the most important thing you should know. Orthopnea is not an unequivocal cardiac symptom because orthopnea can occur in many other conditions like
Asthma, COPD,
so respiratory illness. Any other?
ascites.
Ascites, very good. Ascites. These are the two situations where, so abdominal conditions like cirrhosis of the liver, or respiratory conditions like asthmatic episodes or COPD patients, all can have orthopnea. But these patients cannot have paroxysmal nocturnal dyspnea. So paroxysmal nocturnal dyspnea is a specific symptom for left-sided heart disease. But orthopnea, actually, as you rightly said, is a higher grade of breathlessness, but may not be specific for heart disease because there are other conditions which can give rise to orthopnea, which include respiratory illness, COPD, pneumothorax, fluid diffusion. All this can give rise to orthopnea. And also, ascites also is another situation where the patient may be having orthopnea. So orthopnea, even though it's a higher grade of breathlessness, but as far as the cardiovascular system history and interpretation is concerned, paroxysmal nocturnal dyspnea is much more important. Is it clear to you, Shivam?
Yes.
Okay, right. Go ahead.
There is also a history of on and off cough since last 12 years associated with scanty white sputum, non-foul smelling, which increases on lying down. There is no diurnal variation and sputum is not blood tinged. Cough increases on exertion and decreases on taking rest.
Wait. When the patient is having a cough, can it be a cardiovascular symptom?
Yes, sir. If dyspnea is the first complaint, then cough follows after dyspnea.
Yeah. If it is respiratory,
Then cough would be the first symptom, and dyspnea follows after the cough.
okay. So you should have made a statement there in this particular patient whether the dyspnea is preceding the cough or cough is preceding dyspnea. If the cough
In
is
this,
preceding dyspnea, then it is more likely to be a respiratory symptom. And if the dyspnea is preceding cough, that is more likely to be a cardiovascular symptom. Sometimes it is extremely difficult to differentiate, and unless the patient is extremely intelligent, they may not be able to answer this question. But you can always ask the question to the patient, and the history you can make a statement that the patient is not able to tell me which symptom occurred first. So immediately examiner can be very clear that this student has asked the patient to find out whether it is a respiratory symptom or whether it is a cardiovascular symptom. So that also can be included part of the story. Okay, go ahead. Here, did you ask the story to the patient which occurred first?
yes, sir. Dyspnea occurs first. The patient is having dyspnea from last 15 years, while cough started 1 to 2 years after this.
Okay, so this patient has got dyspnea and the subsequently patient is having cough. So most likely it is a cardiovascular symptom, and the gravity of the symptom also has steadily increased. Okay, go ahead.
There is also history of intermittent palpitations from last 10 years, which were sudden in onset, gradually progressive and irregular, felt on left side of the chest. Palpitations are fast. They are not associated with syncopal attacks. It remains for 1 to 2 days and resolves spontaneously or by taking medicine that decreases the heart rate. There is no other aggravating and relieving factors as told by the patient. Palpitations are not associated with chest pain, diaphoresis, or exertion. Palpitations also increase from the last 4 or 5 days, which are fast and irregular.
So what is your interpretation?
Since the patient is having palpitations and these were intermittent and the palpitations were irregular, so most likely the patient would be having atrial fibrillation.
Yes. Atrial fibrillation is the commonest complication of a pre-existing heart lesion. So this patient has developed atrial fibrillation. And when a patient is having atrial fibrillation as a sequelae to heart disease, what are the common heart conditions which can predispose for atrial fibrillation?
The most common cause would be mitral valve disease.
Mitral valve disease, mitral stenosis, mitral regurgitation, yes.
And also in old ages, coronary artery disease or cardiomyopathy can also lead to atrial fibrillation.
Yes, cardiomyopathy, coronary disease, yes.
And
Thyrotoxicosis is very good. Few more. Can you tell about 10 conditions which can predispose for atrial fibrillation? You have said mitral valve disease, stenosis, regurgitation. We also said about coronary disease. In the Western world, what is the commonest cause of atrial fibrillation?
The commonest cause is non-valvular atrial fibrillation.
Non-valvular?
Non-valvular atrial fibrillation related to coronary artery disease.
No, actually, it is systemic hypertension. In the Western world, the commonest cause of atrial fibrillation is systemic hypertension. Many of these patients with coronary artery disease will have systemic hypertension also, but systemic hypertension is considered as the most important reason because it is more quite prevalent in the society and that can predispose for atrial fibrillation. Okay, right? Yes. So, any other cause?
Drugs like ivabradine can also predispose to atrial fibrillation.
Yes, the ivabradine has been shown to increase the risk of atrial fibrillation. Yes. Similar to the action of ivabradine, can you think of one condition where there can be atrial fibrillation? Ivabradine suppresses the sinus node function.
Sixth sinus syndrome, the most common arrhythmia in sixth sinus syndrome is atrial fibrillation.
Sixth sinus syndrome patients can also have atrial fibrillation as a complication. Yes, what else?
In some cases, aortic valve diseases can also lead to atrial fibrillation.
Very rare, but of course, occasionally aortic stenosis can give rise to, but not that common. Aortic regurgitation very seldom. What else?
Sarcoidosis, heart failure with reduced with preserved ejection fraction like diastolic dysfunction.
Which one?
Heart failure with preserved ejection fraction in which diastolic dysfunction is there, which further leads to LA enlargement like sarcoidosis.
Okay, that can also give rise to whenever there is a diastolic dysfunction of the LV, which can result in the stretch of the left atrium, left atrial dilatation, and they may go for atrial fibrillation. Okay, right? Yes. What else? There are many other conditions.
Electrolyte abnormalities. Electrolyte abnormalities.
Not usual. Which abnormality are in your mind? What abnormalities?
Hypokalemia sometimes lead to stunned atriums, which can lead to slowing down of SA node and further lead to atrial fibrillation.
Which one? Hypokalemia or hyperkalemia?
Hyperkalemia.
What happens to atrium in these patients?
The atria stop contracting.
Yeah. What is it known as?
Stunned atria. Hibernating or stunned atria.
Not hibernating. Anybody? What is the name given when the atrium is not functioning in hyperkalemia? What is the name given? It is atrial paralysis. They develop atrial paralysis, not atrial fibrillation. They develop atrial paralysis, and they can have an atrial in the sinonodal conduction where the atrium is not taking part in the conduction. They usually develop atrial paralysis. Any other few more conditions which can give rise to post-operative patients who have undergone surgery. You must have seen plenty of patients following surgery developing atrial fibrillation. Constrictive pericarditis, another important reason. Atrial septal defect is another important reason.
Mnemonic atrial
Trauma,
fibrillation.
trauma to the heart can develop atrial fibrillation. Binge drinking, patients who develop large quantity of alcohol at one shot, one go, can develop atrial fibrillation. So there are many conditions which can give rise to atrial fibrillation. You should be able to enumerate at least 20 conditions. Okay, these are few conditions. So of course, I agree with you that mitral valve disease is one important condition which should be in your mind. Okay, right. Go ahead. Yes.
There is also a history of swelling in both lower limbs since 5 years, which was insidious in onset and gradually progressive. Initially, there was swelling in foot region, which progressed to knee region after 6 months. She also noticed that there are markings of slippers on the foot she wear during the swelling. Swelling is less during morning and it increases as day progresses. It is relieved on taking medicines, after which there is increase in urine output.
Oh, I want to ask one question. When the patient said that the patient is having edema of the lower limbs, did you ask the patient what happened to your dyspnea at night?
I didn't ask it, but yeah, definitely dyspnea at night would increase if there would be edema in the lower limbs.
You are not clear. You are not absolutely. Your voice is not very clear to me. Can you speak to the microphone so that I can listen to you better? So this patient is started developing edema of the lower limbs. What does that mean to you?
Uh, the patient started having right heart failure.
Yes, the patient started developing right heart failure. So if the patient is having episodes of paroxysmal nocturnal dyspnea, when they develop right heart failure, what happens to paroxysmal nocturnal dyspnea?
In that case, since there is pulmonary arterial hypertension, that
No,
could lead to
don't worry about all those. It has nothing to do with pulmonary arterial hypertension. Patients with tricuspid stenosis can have right heart failure, or patients with significant organic tricuspid regurgitation with stenosis can have right heart failure. You don't
yes,
have to go to the pulmonary arterial hypertension road. This patient has developed right heart failure, and then the paroxysmal nocturnal dyspnea can
decrease because there would be decreased output from the right ventricle.
very good. So did you ask for that story?
No, sir.
Oh. So every point should be asked. And if the patient says that patient started developing edema of the lower limbs, then you should have immediately asked, then what happened to your breathlessness? So that gives additional information that when the patient started developing right heart failure, the paroxysmal nocturnal dyspnea came down or even disappeared. Okay, right. Go ahead.
Patient was admitted in a hospital 8 years back for these symptoms, where she was diagnosed with some cardiac disease and treatment was given for the same. After that, she was given some medicines like blood thinners, medicine that increases urine output, medicines to decrease the heart rate, and three more medicines which she don't remember. She was taking these medicines regularly but skipped them from last week due to financial reasons.
Okay, go ahead.
Negative history. There is no history of decreased urine output, blood in urine, or facial swelling. There is no history of yellowish discoloration of the sclera or urine. There is no history of abdominal pain. There is no history of heat intolerance or neck swelling. There is no history of syncope or chest pain. There is no history of migratory joint pain with fever or rash in childhood. There is no history of abnormal body movement in the childhood. There is no history of painful swelling in palms and soles. There is no history of bluish discoloration of tongues or lips. And there is no history of sudden onset weakness of any part of the body or difficulty in speaking or facial deviation.
Is there any history of claudication of the limbs? Did you ask that story?
No, sir.
Do you think it's important to ask?
Yes, yes, because it might point toward atherosclerosis, which goes in favor of coronary artery.
Lady who is 44 years, having symptomatic for 10 or 12 years, why should you immediately think of atherosclerosis? A patient who is a female less than 40 years, what is the one condition which you can think about?
Embolic episodes.
No.
And Burgess disease.
Eh?
Burgess disease.
Burgess disease is not a female disease.
Yes.
You can think of aorta arteritis.
Yes, sir.
Aorta
Dr.
arteritis,
Rajan.
aorta arteritis, and consequently the patient is having systemic hypertension, they can develop all these complications. So you can ask for a history of limb claudication. Very often they get upper limb claudication and not lower limb claudication. So you can always ask for limb claudication and also include that in the negative story. This patient does not give any history of limb claudication. Okay, good. I think you have taken a reasonably good story. What else?
Treatment history. After getting admitted in our hospitals in last 5 days, patient is given oxygen through a face mask for first 2 days, some IV injections which increases urine output and decreases heart rate, and 2 to 3 oral drugs too. The swelling in her feet decreases and she is now not having breathlessness at rest but get breathless whenever she goes to washroom, which is 15 to 20 footsteps away.
She's class 4 symptomatic almost. She cannot do any activity without developing symptoms. Okay, right? Yes.
Comorbidities. Patient is not having diabetes, hypertension, or any thyroid disorder. Past history. There is no history of tuberculosis, past surgery, blood transfusion, or any drug allergy. Family history. There is no history of similar illness or any sudden cardiac death in the family. Menstrual history. Menarche at the age of 12 years. Cycles are regular with bleeding for 3 to 4 days, and 40 to 50 ml of blood is lost per cycle. Personal history. The patient is taking mixed diet. There is normal bladder or bowel habit. There is no history of smoking or alcohol intake. There is history of disturbed sleep sometimes because of paroxysmal nocturnal dyspnea. Uh,
Wait. You are not told me about her marriage, pregnancy, children. That's very important. In any woman with heart disease, you have to mention about whether she's got married, whether she had conceived, and during pregnancy, what happened to her symptoms.
she got married at the age of 20 years. Her husband name was Subhra, written in the first slide. And she is having two children, one at the age of 20 years and one at the age of 22 years. But she started developing symptoms at the age of 27 years.
That's right. She may have symptoms at 27 years, but during pregnancy, they can have, during that period, they can have significant symptoms. What happens to pregnancy and what are the hemodynamic changes of pregnancy?
In pregnancy, the peripheral vascular resistance decreases.
Yeah, peripheral vascular resistance increases.
Uh,
What are the hemodynamic changes of pregnancy?
in pregnancy, cardiac output increases.
Yes,
Blood
increase in
volume,
cardiac output. Yes.
blood volume increases.
Increase in the blood volume.
Uh, systolic blood pressure increases.
Yeah.
Systolic blood pressure increases.
Usually pressure does not increase. The systolic pressure practically remains the same, but diastolic pressure
Diastolic pressure decreases.
decreases. The pulse pressure increases, diastolic pressure decreases, systolic pressure remains the same, or it may even drop a bit. It does not increase. It usually remains the same or may slightly drop, and the things which actually increase is the pulse pressure. The diastolic pressure also decreases. Yes.
Peripheral vascular resistance decreases.
Yeah, peripheral vascular resistance decreases. So these are the things that happen during pregnancy. Peripheral vascular resistance decreases and all others increase. Blood volume increase, heart rate increase, cardiac output increase. All those things can increase. So when these things happen, what is the commonest lesion which can become more symptomatic?
Stenotic lesions would become more symptomatic.
What do you mean by stenotic lesions?
Lesions like aortic stenosis and mitral stenosis.
Okay, of these two, which one will become more symptomatic?
Mitral stenosis.
Why?
Because the patient would be having more symptoms of left-sided heart failure, while in aortic stenosis, the more symptoms would be of angina only.
No, that is not this. You have to explain. See, what are the hemodynamic changes of pregnancy?
Increase in the blood volume and cardiac output.
Increase in the blood volume, increase in the cardiac output, increase in the heart rate. And what is the effect of these on the mitral valve stenosis?
there is increase in the left atrial pressure because less filling of the left ventricle.
Yes. When there is an increase in heart rate, what happens to the filling time?
Filling time decreases because diastole decreases.
Yes. So there is an increase in heart rate will result in less of filling time. So patients with mitral stenosis will become more symptomatic. Second, increase in the blood volume. What happens?
Uh, more and more blood would go from right side heart up to the left side heart. But since LA pressure is more, so more blood would be there in the pulmonary circulation, leading to pulmonary congestion.
More volume of blood is there, that will result in more stagnation of blood in the left atrium, increase in the pulmonary congestion, and development of symptoms. Okay?
Yes, sir.
కేసీడీ వీళ్ళు తీసుకునే కేసు చాలా డిఫరెన్స్ ఉంటుందన్న
అవును అయితే మ్యారోలోనే చాలా తేడా ఉంది
అట్లా కాదు వాళ్ళు ఏం ప్రొఫెషనల్స్ కదా ఏ పడతారో అందరూ నోట్
Is anybody asking
చేసుకుంటారు
questions? If somebody is asking questions, yes. Otherwise, can you mute yourself so that you are not disturbing others?
తెలుసు 4 పాయింట్లే బట్ ఎందుకు మిక్స్డ్ డైట్ కలుపుతారు మధ్యలో ఏముండవు.
Okay. So, mitral stenosis actually worsens much more than aortic stenosis when the patient is during pregnancy. So patients who are having mitral stenosis can become grossly symptomatic with paroxysmal nocturnal dyspnea, and they can become significantly symptomatic when they become pregnant. So you must always ask for the story of pregnancy and whether there was a deterioration of symptoms, and if there was a deterioration of symptoms after the delivery, what happened? These patients improve after delivery. Okay, right. So you must always ask for a history of pregnancy, delivery, and what happened to the cardiovascular symptoms during that period. So this patient had this patient had 2 children, and during pregnancy, according to you, there was no deterioration. But you are not asked for that, so we can't be certain about that. Okay, right. So anything else you want to tell in the story? Okay, now any volunteers to discuss the story part, just to tell me what are the conclusions that you can draw from the story part. Can any one of you, Aditya, can you discuss this case? Vishwanath, are you there? Anirudh? I think one of you, it's very important for you to come forward and discuss the story, because that will give you greater confidence when you face the examiners. Any volunteers to discuss the story? I would like one of you to come forward to discuss the story, because discussing the story gives the examiner an idea about your understanding of the disease process.
Sir, patient is
I will help
having.
you. Yeah, okay. What is your name?
Sir, Faisal, sir.
Beg your pardon?
Faisal, sir.
Myself.
Yes, sir.
Okay. So how will you proceed to discuss? I will give you certain clues. Well, first question you have to ask after hearing the story is it what is the system affected? Is this a cardiovascular system disease?
So yes, sir. Cardiovascular system.
Why do you say that?
So one is the features of right heart failure, like pedal edema, both right and left with PND, orthopnea, and right heart failure in the form of pedal edema. Then the breathlessness has occurred before.
So patient from the story has got symptoms which is suggestive of the left heart failure as well as right heart failure.
Yes, sir.
Okay. So this patient is having both left heart failure as well as right heart failure. Which occurred first?
Then breathlessness has preceded cough with expectoration, sir.
Yes. The paroxysmal nocturnal dyspnea also occurred first. So this patient had there was a left heart disease, and then subsequently it went to the right heart disease. So what are the possibilities? 43-year-old female. So what are the common causes in a female? When there a female comes, what are the conditions that you should suspect?
So one is infective and endocarditis.
No. Why should you go to infective endocarditis? Where is the
Like
story?
mitral stenosis, sir.
Yes, so rheumatic heart disease. You should suspect.
Rheumatic heart disease.
In a female, you should suspect rheumatic heart disease. What else? 43-year-old female.
So ASD, sir.
ASD, very good. Atrial defect, 3.
So heart failure could be due to secondary to coronary artery.
Yes, this is of course in a 43-year-old menstruating woman is not very common unless there is diabetes or hypertension. This lady does not have any hypertension or diabetes. So 43-year-old female, very low on the list. What are the few other conditions? You can think of some form of cardiomyopathy. The patient may be having cardiomyopathy like restrictive cardiomyopathy. For example, patients with endomyocard fibrosis, they may present initially with left-sided disease and they can go to right heart manifestations. So cardiomyopathy is like endomyocardial fibrosis. What else? Systemic hypertension. These patients with 43-year-old can present with systemic hypertension and that can develop into left heart failure, but they are unlikely to go for right heart failure. Okay, so of these possibilities, which one do you think is most likely? Faisal?
So mitral rheumatic heart disease could be.
Yeah, I think you will have to discuss rheumatic heart disease. So in this patient, if it is rheumatic heart disease, what are the lesions and what is your explanation? Is it a mitral valve disease, aortic valve disease, tricuspid valve disease? What is the
mitral, sir?
You are saying it's a mitral valve disease. Why do you say it's a mitral valve disease?
Symptoms of both left and right heart failure, sir, that goes in favor of mitral valve disease. So.
No. Right side symptoms does not go in favor of mitral stenosis. What you can say is that the commonest valve involved in rheumatic heart disease is
mitral
valve. And the mitral stenosis is most frequent in females. And this patient is giving history of paroxysmal nocturnal dyspnea for a long period. So most likely this patient must be having mitral stenosis. Yes. Do you think that this patient may be having mitral regurgitation also?
It could be there, sir, associated.
What would be the regurgitation is a walling overload condition. What is the important symptom of walling overload condition?
Sorry, sir.
Mitral regurgitation is a walling overload condition. And when the patient is having a walling overload condition like mitral regurgitation, aortic regurgitation, ASD, BSD, all these, what will be the symptom of the patient?
So,
walling overload.
So pedal edema, sir.
No.
Palpitation.
Palpitation. The heart is big, contracting powerfully. They will have palpitation. This lady did not have palpitation. She started developing palpitation when she developed what?
Atrial fibrillation.
Atrial fibrillation. She started developing palpitation when she developed atrial fibrillation and she had irregular palpitation. So there is no history for us to support that the patient is having significant mitral regurgitation. Whether there is mild mitral regurgitation, we can't be certain. But there is unlikely that patient is having severe mitral regurgitation or severe aortic regurgitation. Okay, right, yes. Yes. This patient started developing a right heart failure. What is your explanation?
So stenosis causing backflows, pressure backflows, slowly increasing the pulmonary vascular resistance. So there is leading to right heart failure, sir.
A patient can develop pulmonary arterial hypertension and that can progressively result in RV dysfunction, tricuspid regurgitation, RV dysfunction, and the patient can go for right heart failure. That's one mechanism. Second, do you think that this patient can have organic tricuspid valve disease?
Yes, sir.
Patients with mitral stenosis can have tricuspid valve disease also, and over a period of time, the tricuspid valve disease can progress, and some of these patients can have tricuspid stenosis, and tricuspid stenosis, tricuspid regurgitation, organic tricuspid valve, and they can go for right-sided heart failure. So, yes. tricuspid regurgitation, but you can always keep your mind open, saying that whether this patient had associated tricuspid valve disease resulting in tricuspid stenosis and tricuspid regurgitation organic, and that is the reason that patient has developed right heart failure. Okay. Yeah. Do you think this is ASD?
Age favors the.
Do you think that this is ASD?
Age goes in favor, sir.
Eh?
Age.
Okay, you will not consider age alone. I'm saying general, as a whole. Do you think that this is ASD? What is the one story which makes you think that it is not ASD?
So, paroxysmal nocturnal dyspnea.
Very good. The patient is giving history of paroxysmal nocturnal dyspnea, and that cannot happen in a patient with atrial septal defect. Even if the patient is having mitral stenosis, if the patient is having associated ASD, that patient will not have paroxysmal nocturnal dyspnea. So, presence of ASD, presence of paroxysmal nocturnal dyspnea rules out that the patient is having atrial septal defect. Okay. Can this be endomyocardial fibrosis?
Not sure,
Yeah.
sir.
Oh, yes, endomyocardial fibrosis can be considered. Like it can happen at this age. Patients can start with the left side symptoms, and they can go to involve the right side, and then they can present with severe right heart failure. So a possibility of endomyocardial fibrosis definitely can be considered. But if you think of the more probable diagnosis, I would go for rheumatic heart disease. Okay, right. From the story, from the nature of illness, sex, female patient, all put together, I think a possibility of rheumatic heart disease should be considered. Okay, right, that's one point. And when you consider rheumatic heart disease, the history of paroxysmal nocturnal dyspnea goes strongly in favor of associated mitral stenosis.
And atrial fibrillation also goes.
Yes, atrial fibrillation goes in favor of associated mitral valve disease. It is in mitral valve disease that you develop more and more of atrial fibrillation, and patient is now grossly symptomatic, almost class 4 symptomatic. That also goes in to say that patient most likely must be having with this rheumatic heart disease, it could be associated mitral stenosis and a possibility of some degree of mitral regurgitation we cannot rule out. And patient may be having pulmonary arterial hypertension and right heart failure, or patient may be having associated right heart disease like tricuspid valve disease organic, and that has resulted in right heart failure. Okay, so with this provisional diagnosis, we will go to the clinical findings and find out what is the diagnosis. Okay, Shivam, can you?
Yes.
Any other point would any student would like to bring up so that we can discuss that point? Do you think that we should consider systemic hypertension, Faisal?
So there is she's not a known case of hypertension, so very unlikely, sir.
Yeah, there is hypertension can be easily diagnosed by hypertension can be diagnosed easily by taking the blood pressure, and no doctor has told her that she's having systemic hypertension. So from the story, at least we cannot diagnose systemic hypertension. If it was systemic hypertension, then you should think always a possibility of aorta arthritis, especially in a female when there's systemic hypertension and symptomatic for many years. You should always think of a possibility of aorta arthritis also, and carefully examine all the pulses of the neck, of both the upper limbs, both the lower limbs, to whether the patient is having any arterial obstructive disease also. So all those things should be in your mind when you examine the patient. Okay, now we'll go to the examination. Shivam, go ahead. So our clinical, yes.
Provisional diagnosis after history. Based on history, Kalavati, a 43-year-old female with complaints of dyspnea, cough, and palpitation, is probably having an acquired heart disease, possibly a rheumatic valvular heart disease, possibly of mitral stenosis, with left and right-sided heart failure with atrial fibrillation.
Yes. You can also include tricuspid valve disease also needs exclusion because she has developed right heart failure.
Yes.
So I agree with you that right heart failure can be explained by development of pulmonary arterial hypertension, tricuspid regurgitation, and heart failure. But you can also discuss the possibility of tricuspid valve disease resulting in right heart failure in a patient with rheumatic heart disease. Okay, go ahead. Findings.
Examination, general physical examination. A 50-year-old female, thin built, moderately nourished.
No, you said in the beginning, you said she's 43 years, suddenly became 50 years.
43.
Because initially you said she's 43-year-old female. Now suddenly it just become 50 years.
43.
Okay.
Thin build, moderately nourished, conscious, cooperative, oriented to time, place, and person is examined in a well-lit room in sitting supine, semi-recumbent, left lateral, and standing position. Blood pressure taken in sitting position. It was 120 by 74 in right upper limb, 122 by 74 in left upper limb, 126 by 76 in right lower limb, and 126 by 76 in left lower limb.
Any conclusions from the blood pressure? What is the pulse pressure? Is it normal or higher?
Pulse pressure is 46, approximately 46. So it is borderline actually. It is less than 40.
In a patient with heart failure, you said patient is having right heart failure, left heart failure, everywhere. What will be the pulse pressure? What will be the pattern of blood pressure in that such a patient?
It should be less than 40.
Usually the pulse pressure is very good. They will have a low cardiac output and usually will have a low pulse pressure. So if you think that the pulse pressure is slightly higher, how will you explain it?
There can be associated regurgitated lesion as well, like mitral regurgitation or aortic regurgitation.
Mitral regurgitation will not give rise to increase in the pulse pressure. But aortic regurgitation, I agree with you that you can, from the blood pressure recording, I think you can think of some degree of aortic regurgitation. Of course, that has to be kept in mind, and you should carefully look for an early diastolic method. Because a patient who is having mitral stenosis, patient who has got pulmonary arterial hypertension, patient who is in right heart failure, the 120/74 blood pressure recording is odd. That patient usually will have a very low pulse pressure. So 120/74, you have to give some other explanation. Any other explanation? In a female, when they have got mitral stenosis with right heart failure, can they have a warm extremities? Can they have a slightly higher pulse pressure?
Maybe the patient would be in sepsis, which can also lead to increase in the pulse pressure.
Not sepsis. Anybody? These patients can have hepatomegaly, and if they start developing some degree of hepatic failure because of the cardiac cirrhosis, there can be reduced metabolism of estrogen in the liver, and estrogen circulation can result in peripheral vasodilatation and sometimes a higher pulse pressure. So patients with mitral stenosis, severe mitral stenosis, who start developing cardiac cirrhosis or the cardiac cirrhosis can have sometimes more estrogen in the circulation, and they can have warm extremities and also a slightly higher pulse volume. And so that's usually the extreme cases. So this patient is in extreme condition. So you can give an explanation by saying that it may be because of the higher level of circulating estrogen. Would you get the point, Shivam?
Yes, sir.
Okay, go ahead.
Pulse is 82 beats per minute, irregularly irregular, variable in volume, normal vessel wall condition with no radial or no radiofemoral delay. Pulse deficit is 14. Respiratory rate is 17 per minute, and it is thoraco-abdominal. Jugular venous pulse
What is the normal respiratory rate?
12 to 16 per minute.
Usually 14, round about 14. Okay, like this. Go ahead.
Jugular venous pressure, it is 8 centimeter above the sternal angle and 13 centimeter above the right atrium. The A wave is absent and prominent V wave is seen.
How do you make out between A wave and V wave?
Sir, the V wave, The A wave is due to the contraction of the RA. So A wave comes just before the apex peak.
Okay. This is just before the carotid pulse. It's easier to compare with the carotid pulse. The wave which occurs before the carotid pulse is A wave, and B wave.
B wave would come along with the carotid pulse.
B wave does not occur along with the carotid pulse. The peak of the B wave occurs after the carotid pulse.
Yes, sir.
So, but in a patient with tricuspid regurgitation, sometimes the one wave which may correspond to carotid pulse, this wave is known as
CV wave.
CV wave. When there can be CV wave, which can sometimes correspond to carotid pulse. Okay, that is one point. What is the next point? Now, differentiating between A wave and B wave.
Generally, A wave is slightly more than the V wave.
But that depends upon the lesion. Patients with tricuspid regurgitation, B wave will be much taller.
Yes, sir. And A wave would be absent in cases of atrial fibrillation also. That
A wave is
absent in atrial fibrillation.
No. It's not the question of absence. If the A and B both are present, what are the features which will help you to separate A wave from B wave? One we have already mentioned. A wave precedes the carotid pulse. V wave follows the carotid pulse. Yes. Two. A wave is a jerky wave. It is sharp rise and a sharp fall. V wave.
Slow rising normally.
Slow rise and a
slow fall.
Why should there be a slow fall?
Because there is a flowing of the blood from the RA to RV.
Okay.
And RV pressure is generally, it would go slowly, and A wave is due to atrial contraction. At that time, there is more pressure in the RA.
No, the V wave is a slow rise and a sharp fall. The conditions, can you tell me the conditions in which V wave can have a slow fall?
It can be in cardiac tamponade.
Cardiac tamponade degree. Okay, in cardiac tamponade, Y descent will be shallow or absent. Okay, so in cardiac tamponade, yes, I agree with you. Anything else?
Tricuspid stenosis.
Yes, tricuspid stenosis, one condition where V wave can be very shallow. 3.
A right ventricular systolic failure.
Right ventricular?
Failure.
No. That's not enough. Need little more explanation.
Pulmonary artery hypertension.
No. What type of failure? Is it systolic failure, diastolic failure, compliance failure?
Diastolic failure.
Eh?
Because diastolic failure.
Diastolic failure. The patients who have got a reduced compliance, who cannot relax properly, those patients can have reduced, or rather, the Y descent will be significantly prolonged. So you already mentioned those conditions. Okay, very good. So the conditions where the Y descent is it is a slow rising and a sharp fall, but the sharp fall can be absent in tricuspid stenosis. It can occur in patients with the cardiac tamponade degree. It can also happen in patients with the diastolic dysfunction, where the diastolic relaxation is impaired. That will result in reduced Y descent. In atrial fibrillation patients, do you get a X descent?
No, in atrial fibrillation, H descent would be absent, but X dash descent would be present.
Which one?
X dash.
Yes, X dash will be present. Very good. Those patients, the actual X will not be present, but you can get an X dash. X dash is due to what?
X dash is because of the closure of the tricuspid valve.
X dash is due to what?
Tricuspid valve going into the RA.
I could not follow you. What did you say? Let me make it very clear. What is the mechanism of X dash?
X dash descent is because of the closure of the tricuspid valve.
No. It is not due to closure of the tricuspid valve. When there is a closure of the tricuspid valve, is it a negative wave or a positive wave?
It is a positive wave, C wave.
Positive. That's a C wave. What is the mechanism of X dash or the descent after the C wave?
When the tricuspid valve closes, it Once it goes up into the RA, it relaxes and goes downwards into the ventricle, leading to extra.
Yeah, whereas as the ventricular ejection progresses, the tricuspid valve is pulled down into the right ventricle. That will generate the extract. So in the patient with atrial fibrillation, you will not get the exact X wave, which is due to atrial relaxation, but you can get an X dash wave, which is due to the pulling down of the tricuspid valve into the right ventricle. Okay, right. Go ahead. Yes. I think you are doing reasonably well, Shivam. Okay, right. Go ahead.
Pallor is absent. Icterus is absent. No signs of facial congestion. There is no cyanosis. Uvula is central in position and non-pulsatile. Clubbing is absent. There is no evidence of ocular nodes or general lesions. Pedal edema is present and pitting in nature. There is no generalized lymphadenopathy, and there is no engorged or dilated veins over any part of the body.
Okay.
Serious examination. Inspection. Chest is bilaterally symmetrical. There is no breast abnormality. Skin is normal over the chest region. There is no precordial prominence. There is no.
How does this breast abnormality come in cardiovascular examination? You said serious examination and no breast abnormality. What is the need?
On inspection, we are inspecting the precordial region, so there is no visible gross abnormality.
Your precordium is what is precordium?
Precordium is the area that is above the heart.
Yeah, not above the heart, superficial to the heart. Above the heart is in the neck. So it's superficial to the heart. The part of the chest wall which is anterior or superficial to the heart is known as the precordium. It does not include breast. So it is a part of the chest wall which is in front of the heart. So when you are doing a precordial examination, you don't have to make a comment about no breast abnormality. Okay, right, go ahead.
There is no engorged veins over chest region. There are no scars, sinus, or fistula. Apical impulse is present in 6th and 7th intercostal space, 1 centimeter lateral to mid-clavicular line.
How do you, in inspection, how can you make out whether it is 6th or 7th intercostal space in a female? Extremely difficult.
Yes, but actually the female was quite thin built, so it was visible in 2 intercostal spaces.
No, you quite possible that you might have seen in 2 intercostal spaces, but I am asking you, how can you make out whether it is 5th or 6th or 7th or 8th? I would mention that if you are doing a separate inspection, it is better not to mention about the exact intercostal space. You can say that apically the cardiac impulse is seen 1 centimeter lateral to midclavicular line, or I think that would be enough. It may be extremely difficult for you to say whether it is 6th or 7th intercostal space. Okay, go ahead.
Heave is visible in left parasternal area. Epigastric pulsations are seen. There is no other visible pulsation in aortic, pulmonary, tricuspid, neoaortic, or epigastric region. There is no ectopic pulsation.
Okay.
Palpation. All findings of inspections are confirmed. Apex beat is palpated in 6th and 7th intercostal space, 1 centimeter lateral to mid-clavicular line. Hyperdynamic in nature.
No, wait. What do you mean by apex beat is palpated in the 6th and 7th intercostal space? What do you mean by that? Define apex beat.
It is the outermost and lowermost point of maximum cardiac impulse.
No, not maximum cardiac impulse. No, wrong. Anybody who would like to define apex beat?
So outermost and lowermost definite cardiac impulse.
Yeah, that's all. It is the apex beat is the lowermost, outermost point. It is not even an area, it's a point where the definite cardiac impulse is felt or seen. So you cannot have an apex beat in the 6th and 7th intercostal space. It is a point. So you have to locate the outermost and lowermost point. So it is definitely in the 7th intercostal space according to your description, and 1 centimeter lateral to the midclavicular line. Okay. So don't use the word in 2 intercostal spaces you are feeling that speed. You can make the statement that cardiac impulse, apical impulse is felt in the 6th and 7th intercostal space, but not apex beat.
Okay.
Apex beat is different from Apical impulse.
Yes.
Apex beat, as somebody else has defined. Who defined the apex beat? Is it Faisal?
Yes, sir.
Oh. The apex beat is the lowermost and outermost point where a definite cardiac impulse is felt or seen. So it is a point. So you cannot use the word. But if you want to say about the impulse in the 6th and 7th intercostal space, you can say apical impulses are felt in the 6th and 7th intercostal space. That's fine. But not apex beat. Okay, right. Yes.
P2 is palpable in pulmonary area.
No. You are in the apex. You have to mention one more point. When you examine the apex, one is you have to locate the apex beat. 2, you have to describe the character of the apical impulse. And 3rd, any sound or thrill palpable.
Okay.
You should always mention the region of the apex, whether there is any sound palpable or any thrill felt by turning the patient to left lateral position and carefully looking for it. Okay, right? Yes.
P2 is palpable in pulmonary area. No other heart sounds are palpable. Thrill is
You're coming back
palpable. Thrill is palpable in mitral area, asynchronous with carotid pulse. It is diastolic thrill is present. Grade 3 parasternal heave present. Epigastric pulsations are palpable. There is no other palpable thrill, rub, or pulsations in any other area, and tracheal tug is absent.
Is it common to have a systolic thrill at the apex?
If in mitral regurgitation, normally there is a jet which is directed posteriorly, so we don't have thrill associated with mitral regurgitation. If a systolic thrill is present in this mitral area, then we can think of VSD.
Yes, what VSD? Very good. What VSD?
Small muscular VSD.
Yes, a small muscular VSD in the region of the apex, near about the apex. Whenever there is a small muscular VSD near about the region of the apex, when you can sometimes get a thrill. So thrill in mitral regurgitation is very, very unlikely, or it can be absent because the abnormal jet is directed posteriorly into the left atrium. So a thrill in the apical region, if there is a systolic thrill, you must always suspect the possibility of a muscular VSD near the region of the apex. Okay, right. Go ahead. Very good. I think you are doing very well, Shivam. Good. Right, next.
Percussion of the left heart border, dullness corresponds to the apex beat. Second, left and right intercostal spaces are resonant, and right border dullness extends 3 centimeters beyond the right sternal border.
Normally, is it second, left and right intercostal spaces are absolutely resonant, or there can be some dullness?
Normally they are resonant, but if there is dilatation of the vessels, great vessels, then they can be dull also.
Yeah. No, sometimes you can up to 1 centimeter in normal people also there can be, sometimes you will be able to get an impaired node. When it extends beyond 1 centimeter on either side, it is definitely abnormal. But you can sometimes hear a dull note up to 1 centimeter beyond the from the medial aspect of the intercostal space. Okay. The right border dullness extends. What is the reason?
This can be because of RV hypertrophy or LA enlargement also.
Which one?
RA or LA enlargement. Right atrium or left atrium enlargement.
How can the left atrial enlargement give rise to dullness in the right sternal border?
Because when left atrium enlarges, it goes towards the direction of the right border of the heart.
Is it anteriorly or posteriorly?
It is the posterior most of it.
Then a posterior dilatation can it give rise to dullness?
No.
No, it cannot give rise to. I agree with you that the LA can extend, it can distend towards the right side and may go beyond the right border of the heart, but there is a posterior structure and cannot give rise to dullness in an anterior percussion. So whenever there is a dullness beyond the right sternal border, possibilities are: 1, right atrial enlargement; 2nd,
right ventricular enlargement.
No. Right ventricular enlargement will never give rise to the dullness extending onto the right border. Right ventricle is an anterior structure.
Pericardial effusion.
Pericardial effusion. Yes, very good. Pericardial effusion. These are the 2 conditions you should suspect. a pericardial effusion or a enlargement of the right atrium, which can give rise to dullness beyond the right sternal border. In this patient, which one are you suspecting?
In this patient, we are suspecting RA enlargement.
RA enlargement, very good, because this patient has gone in for right heart failure. So everything is suggestive of a right heart failure. So there can be a right atrial enlargement, and that can be the reason for the dullness extending beyond the right sternal border. Very good, Shivam. Okay, go ahead. Yes.
Auscultation. Auscultation is done in mitral, tricuspid, aortic, pulmonary, and neo-aortic area by inching method. S1 is variable.
I don't think you should describe all those things. Auscultation you have to do all over the precordium. There is no point in saying that I have auscultated mitral, tricuspid, aortic, pulmonary. No, you have to auscultate all over the precordium. There is no restriction to 5 areas, but you have to auscultate all over the precordium. But you can describe where it is, whether the events are best audible in which area. That's fine. But the auscultation is all over the precordium. Yes.
S1 is variable but mostly loud.
Very good.
S2, P2 is loud with normal.
No, that's not enough. When you describe a sound, the descriptions are one. S1 is audible, or that's the first point. Where is best audible? It's best audible in the mitral area. It's variable in intensity, mostly loud. So 4 points. One, whether it is audible. Where is best audible? Then what is the nature of best audible
in mitral and tricuspid areas.
No, you cannot. Best audible cannot be in 2 areas. Best audible only in 1 area.
Best audible in mitral area.
Mitral area. Yes, it is best audible in the mitral area. It's variable intensity, but mostly loud. Very good. Yes.
S2, P2 is loud with normal splitting. Best heard in pulmonary area, but splitting is heard in all the areas.
So this patient has got a S2 loud. It's heard all over the precordium. Normal splitting. P2 is loud. Okay, right. Yes.
S3, S4 are not heard.
Okay.
Adventitious sounds are loud. A high pitch opening snap is heard best just medial to the apex.
Okay. Now, why do you say the adventitious sound? It is not an adventitious sound. You should say that the opening snap is audible. You don't have to give all these adjectives. There is an addition. You get lot of sounds which are abnormal, but then you don't have to use the adventitious sounds. Adventitious sounds are mostly described in the lung field. So you can say there is an opening snap is audible. What are the things that you should describe with opening snap?
S2.
What do you mean by a loud pitch? What do you mean by loud pitch? Pitch is the loud one. What the pitch can be?
Loud pitch means it is best heard with the diaphragm of the system.
No, wrong. Pitch can be either a low pitch sound or a high pitch sound, not a loud pitch. That's a wrong statement.
A loud high pitch.
You can say the opening snap is loud and high pitched. The pitch, when you describe the pitch, it could be high pitched, low, medium pitched, or low pitched. There are 3 terms. There is nothing like loud pitch. That's a wrong statement. So it is a high pitched sound. And then what all things will you describe in opening snap?
A2 was gap.
Yes, you have to say whether it is close to A2 or away from A2 or moderate to away. What you have to describe that. What is A2 is interval?
Normally it is 0.4 to 0.12 seconds.
0.4 to 0.12.
0.04 to 0.1.
Yeah. 40 milliseconds to
120.
Yeah. Some people say 130. Which range is close? Which range is intermediate? Which range is away?
0.4 to 0.7 is close.
Yeah, 40 to 70 is close.
70 to 100 or 110 is middle, and 110
70 to 100 roughly is moderately away, and 100 to 130 is definitely away. Yes. So actually you can have 30. So 40 to 70, 70 to 100, 100 to 130. Okay, right. Yes. Okay. So
A mid-diastolic, grade 4 rumbling, low pitch, decrescendo murmur is best heard in the mitral area with bell of stethoscope in left lateral position, which is non-radiating and decreases on inspiration, standing in Valsalva, and increases on sweating.
Now, what do you mean by non-radiating? Where did you look for radiation?
Uh, Radiation in axilla, and we look for radiation.
Are you expecting diastolic murmur to radiate to the axilla?
No,
Are you
no, it
expecting?
doesn't.
Well, then why do you want to describe that as the non-radiating? Usually, a murmur is radiated in the direction the murmur is happening. So, in a patient with mitral stenosis, what is the direction of the murmur?
Direction is from LA to LV, that is posterior to anterior.
Yeah, posterior to anterior. The abdominal jet is coming anteriorly and downwards.
Yes.
So down and anterior. So the diastolic murmur of mitral stenosis can be conducted to the atmosphere, not to the left axilla. Left axilla is a posterior structure, and you don't expect the mitral stenosis murmur to conduct to the axilla.
Yes.
So don't make wrong statements. See, making a wrong statement also, you have been doing very well, but you are non-radiating actually has pulled down your impression on me. You should not use a wrong statement.
Okay, sir.
That's right. Yes. Right.
A pansystolic grade 3.
One more point. You said decreases on inspiration. That's a very tricky answer for mitral stenosis. During inspiration, what happens to the heart rate?
During inspiration, the heart rate increases.
In what heart rate?
Increases.
Increases. When the heart rate increases, what happens to the mitral stenosis murmur?
It decreases.
Eh? When the heart rate increases. When the heart rate increases, what happens to mitral stenosis murmur? When the heart rate increases, what happens?
It increases.
It increases. It increases. So there's a tricky, it is slightly tricky there. That in a patient with actually in a patient with mitral stenosis during inspiration, less volume of blood is coming to the left atrium. So you think that the murmur may decrease. But when the heart rate increases, the murmur may increase. So you cannot blindly make a statement that decreases on inspiration. Did you really auscultate for it? Or you made a statement thinking that this is a left-sided murmur and hence during inspiration it should decrease? I would like to know, honestly.
Auscultated.
Did you make this statement by doing a proper examination, or you made this statement because you thought that this is a left-sided murmur and should decrease on inspiration?
No, sir, I did a proper examination. It was increased. It was decreasing.
Okay, then it's all right. But you must also understand that during inspiration, the mitral stenosis murmur can actually increase. Even though it's a left-sided murmur, that is because the increase in heart rate can result in a louder murmur. Okay, right. Yes. If you know that, you can do a proper examination. Okay, right. Then
A pansystolic grade 3 high pitch.
Decrease on standing and Valsalva.
Yes.
Can there be a significant change in severe mitral stenosis because already the patient is in atrial fibrillation, the left atrium is hugely dilated? Do you think that there is going to be a significant change with Valsalva? And it's extremely difficult to do Valsalva in a class 4 symptomatic patient. How did you do a Valsalva in this lady? Can you really do a Valsalva? And did you make her patient squat and all those things? She may find it extremely difficult to squat and stand up. I don't think you should make too many statements which are practically impossible. This patient is class 4 symptomatic may find it extremely difficult to do a Valsalva. She may find it extremely difficult to squat. So, and also your statement about decreases on inspiration also, I will take with a pinch of salt. You might have made a wrong assessment. So try to make statements. There are many things that you can do. It does not mean that you should do everything in every patient. So there are patients who are really sick and you may not be able to do it. You can make a statement that since the patient is sick, I did not do a Valsalva and squatting on this patient. That would be the correct statement. Okay, right? Yes. Go ahead.
A pansystolic grade 3 high pitch blowing plateau murmur is best held in the mitral area with diaphragm of stethoscope in left lateral position, which is radiating to the axilla and decreases on standing and increases on hand grip. A pan-systolic grade 2 high-pitched plateau murmur is best heard in tricuspid area with diaphragm of stethoscope in supine position, and it increases on inspiration and decreases on standing.
Decrease on standing and Valsalva. Okay, I don't know whether you are really done this because it's otherwise the patient should be much less symptomatic. Class 4 patient cannot do Valsalva.
The patient is
They won't be able
improving
to. It is impossible for a patient to do Valsalva if the patient is class 4 symptomatic. So things which you cannot do, you need not mention. You can make a statement that I didn't do Valsalva because this patient is class 4 symptomatic. It is wrong to make the patient do Valsalva when she is class 4 symptomatic. Okay, right, go ahead. Now, how does the murmur increase on hand grip?
the murmur in mitral area, that is the pan-systolic murmur, is increasing on hand grip.
Why it is increasing on hand grip?
Since on hand grip there is increase in the peripheral vascular resistance,
So
leading to increase in the left ventricular systolic pressure, which leads to the increase in the murmur of MR.
Okay. In a patient with the mitral stenosis with mitral regurgitation, what can happen to the murmur when the patient is doing a Valsalva? Or rather, when the patient is inspiring, what can happen to the murmur of mitral regurgitation? Who said the murmur, decreases on standing, a Valsalva, squatting. You didn't mention anything about breathing. What happens to the murmur of mitral regurgitation when the patient takes a breath in?
When the patient inspires, there is a decreased blood going to the left side of the heart. So in that case, the murmur of the left side of the heart should decrease actually. But most of the time, the murmur of MR doesn't change with these maneuvers.
Why? Especially if the patient is having mitral stenosis with mitral regurgitation, there won't be any significant change. There is a hemodynamic mechanism that in a patient with mitral stenosis with mitral regurgitation, actually the mitral regurgitation murmur can increase on inspiration. Can you give an explanation? During inspiration, what happens to the venous return to the left side of the heart?
It decreases.
Decreases. When the less volume of blood coming to the left atrium, what will happen to left atrial pressure?
It decreases.
It decreases. So when the left atrial pressure decreases and the LV contracts, what will happen to mitral regurgitation?
The murmur would increase.
Murmur should increase. So in a patient with mitral stenosis with mitral regurgitation, sometimes during inspiration, actually the mitral regurgitation murmur can increase. You do a careful examination that in a patient with mitral stenosis with mitral regurgitation, where there's a large volume of blood is already in the left atrium and the venous return to the left atrium comes down, the left atrial pressure becomes less, and that can result in a greater mitral regurgitation. And during expiration, what happens?
During expiration, the venous return to the blood in the left side, it increases.
Yes. So what happens to left atrial pressure?
It increases.
Increases. So what happens to mitral regurgitation?
The murmur would decrease.
Decrease.
In cases of along with mitral stenosis.
Yes. So in patients with mitral stenosis with mitral regurgitation, the murmur can actually increase on inspiration and decrease on expiration, even though it's a left sided murmur. But of course, you have to do a very, very careful examination to be definite about that. But in a patient with atrial fibrillation, all these variations are impossible to make out. Okay, right. Go ahead. Okay. No, I think that something happened to your. Okay, right. Yes.
CNS examination, there is no focal neurological deficit. Respiratory system examination, bilateral lung fields are clear. Abdominal examination, there is slight right hypochondral tenderness present and liver is palpable 2 centimeter below the costal margin with a liver span of 15.5 centimeter.
Okay. It's extremely difficult to take the measurement. So, okay, now we are allowed to interpret the clinical findings. So this patient is having, what are the relevant clinical findings?
Apical impulse is outward and downward. Apex beat is also downward and outward.
Okay.
Pulse is irregular.
Okay.
And pulse deficit was 14.
Okay. So you could tell the interpretation also. Patient is having irregular pulse. So the patient is having
atrial fibrillation.
Atrial fibrillation. Okay. Apex beat is in the, you said it is in the 7th intercostal space. So it is down as well as out. So what does that mean?
It can be because of LV enlargement.
Yes,
it is eccentric hypertrophy of the left ventricle.
The looking at the apex beat, you have to think the patient is having biventricular enlargement, because you have said there is a good parasternal lift, so right ventricle is enlarged, and there is evidence of a significant shift to the apex down and out, indicating that the patient may be having some degree of LV enlargement also. What is the reason?
Maybe associated mitral regurgitation.
Associated with mitral regurgitation, this patient is having a pansystolic murmur, which is mitral regurgitation, and you have to suspect that probably there is some degree of maybe having moderate mitral regurgitation, which has given rise to some degree of LV enlargement also. Okay, right. Yes. Then what else? What else this patient is having?
Grade 3 parasternal heat was present. A thrill, diastolic thrill is present in the mitral area.
Yes, there is a diastolic murmur in the mid-diastolic murmur in the
mitral area.
What are the, can you enumerate about 10 causes of mid-diastolic rumble at apex?
So it can be because of in flow murmur in mitral regurgitation.
First say the commonest. What is the commonest?
ASD.
What is the commonest cause of a mid-diastolic murmur at apex?
Mitral stenosis.
Mitral stenosis. You must, when you examination, you must always tell the commonest cause. So mitral stenosis. 2.
It can be because of flow murmur in mitral regurgitation.
Yes, increased flow across the mitral valve can happen in mitral regurgitation, ventricular septal defect, patent ductus arteriosus. Okay, 3.
It can be because of Austin Flint murmur in aortic regurgitation.
Very good, Austin Flint murmur. 4.
In some cases in ASD as well, we can have mid-diastolic murmur.
Okay, in patients with ASD with a large right ventricle, the mid-diastolic rumble of the tricuspid valve may be audible at the apex. Very good. Yes. 5.
So left atrial myxoma can be there.
Atrial myxoma. 6.
So core triatrium can be there.
Yes, core triatrium. 7.
Tricuspid stenosis.
Tricuspid is very unlikely to be heard at the apex. Okay, it can be mid-diastolic rumble, sometimes parasternal region. Okay, right. Mid-diastolic rumble can be tricuspid stenosis, yes, but not unlikely to be heard at the apex. And tricuspid stenosis is almost always associated with mitral stenosis if it is rheumatic, and then a murmur at the apex is due to mitral stenosis. Anybody? At least one more.
The Carey-Coombs murmur.
Very good, Carey-Coombs murmur. So Carey-Coombs murmur, that's another murmur that you can think about. So these are all the causes of a mid-diastolic rumble at the apex. Out of these, which one you think in this patient is having?
This patient is having mid-diastolic murmur of mitral stenosis.
Why did you say that?
It is associated with opening snap 1.
This is having an opening snap.
Then
the patient has got associated, the patient has gone into significant pulmonary arterial hypertension. All the features are highly suggestive of
mitral
stenosis. Okay, right. The patient is having, so you think that this patient is having, how severe is this stenosis?
Pardon?
How severe is the mitral stenosis? How do you assess the severity of mitral stenosis?
One is A2 OS gap.
A2 OS level 2.
Length of the murmur.
Length of the murmur.
Third is pulmonary hypertension.
Presence of complications like atrial fibrillation, pulmonary arterial hypertension. Okay, right.
RBP.
In a patient with atrial fibrillation, how will you assess the A2OS interval? How will you assess the length of the murmur? Because the cycle is going on changing.
Sir, we will assess the A2S gap after a big cycle.
Yeah, after a long cycle, you look for the A2OS interval. And the length of the murmur?
We'll assess for the length of the murmur in a long cycle.
In a long cycle. Very good, excellent. The length of the murmur is evaluated in the long cycle, and the A2OS interval is evaluated in the cycle following the long cycle. Explanation?
Sir, if there is a long cycle, then more blood would enter the left atrium.
Yeah? When the long cycle, more blood will enter the left atrium. More blood from the left atrium will drain to the left ventricle, decompressing it.
Decompressing it. So murmur, the length of the murmur would be more in this case. So we'll assess the length of the murmur in the long cycle. And after this, since the left atrium is decompressed now, we'll check for opening snap and A2 gap in that cycle.
Yes, even after a long cycle, if the A2OS interval is still closed, that obviously means the patient is having severe mitral stenosis. Very good. I think you have done it extremely well. I think you are a good student, I think. Because my evaluation after discussing the clinical findings is that you are a good student. Okay, right? Yes. So A2OS interval is evaluated in atrial fibrillation, the cycle following the long cycle, and the length of the murmur is evaluated in the long cycle. Okay, so here the you didn't mention about the A2OS interval. Is it close?
Yeah, it was close.
It was close.
But one doubt I was having that how to measure that O2S gap in milliseconds. How to measure the A2OS gap in milliseconds?
Oh, it is impossible to measure. It is only an impression. You can only say whether it is the A2OS interval is close, moderately away, or away. I don't think you can measure it. It's impossible. Okay. And when you are asked a theoretical question, you can say that if it is close, it is 40 to 70 milliseconds. If it is moderately away, 70 to 100 milliseconds. And if it is really away, it is 100 to 130 milliseconds. That is only a theoretical answer, but practically it is impossible. It is an impression. Whether it is, and of course, the A2OS interval, everything is also depending upon the heart rate also. Heart rate also modifies A2OS interval. If the patient is having a fast heart rate, the A2OS interval can be very close, even in a patient of moderate mitral stenosis. So heart rate also plays a part in deciding the A2OS interval. Okay, right, yes. So, okay, that's very good. So what is your clinical diagnosis?
So, provisional diagnosis. Based on history and examination, the patient seems to be having an acquired heart disease.
No, why do you say this is something which I don't like? You are doing a provisional diagnosis. Why should you say that the patient seems to be having acquired heart disease and all? This is a rheumatic heart disease.
Okay.
I don't think you have to do all these things. Say etiology, rheumatic heart disease. Morbid anatomy. What is the morbid anatomy?
Possibly severe mitral stenosis with moderate mitral regurgitation, with mild tricuspid regurgitation, with pulmonary arterial hypertension.
And why did you say that mild tricuspid regurgitation?
Mild to moderate. Actually, the murmur was of MR was grade 3 and of TR was grade 2. So,
how do you assess the severity of tricuspid regurgitation?
So one is intensity of murmur.
No, intensity of murmur will never tell you about the severity of tricuspid regurgitation. That depends upon the pulmonary arterial hypertension.
Then symptoms.
Right parasternal lift. The parasternal lift that parasternal lift is very significant. That shows the RV is dilated, and you have to think of significant tricuspid regurgitation. Second is presence of a wave in the neck.
Prominent V wave. Prominent
V wave. You have described that this patient is having a very prominent V wave. So, and a very significant parasternal lift. So, both, and also the size of the right atrium. This patient is having the right atrial enlargement indicated by 3 centimeters beyond the
right parasternal area.
right parasternal region, indicating the right atrium is enlarged. All these put together, I will definitely think that the patient is having at least moderate tricuspid regurgitation, if not severe.
Okay.
So moderate tricuspid regurgitation. Even you can put severe tricuspid regurgitation with pulmonary arterial,
with pulmonary artery hypertension, with atrial fibrillation, and right and left heart failure, NYH is 3 to 4, with no evidence of infective endocarditis or acute rheumatic heart disease.
Why do you say the left heart failure?
Because the patient is having dyspnea and orthopnea as well.
No, but then that is my story. Clinical examination, how will you make out left heart failure?
One is on auscultation of the lungs. There might be fine crepitation in the basal region.
So here you said chest is clear. So how can you say that this patient is having left heart failure clinically? So this patient is having definitely right heart failure, and you can say that left heart failure by history. But if you are detected bilateral basal crepitations, then you can definitely say that this patient is having associated left heart failure also. Okay, right. Now, any other differential diagnosis you would like to entertain? Do you think that this is left atrial myxoma?
But yes, sir. But in left atrial myxoma, a mid-diastolic murmur can be there, but there won't be any pan-systolic murmur as well.
So sometimes left atrial myxoma can distort the mitral valve, and sometimes they can also have sometimes mitral regurgitation murmur. May not be in all cycles. In some of the cycles, the left atrial myxoma may not be pushed out into the left atrium, and sometimes it may distort the mitral valve, and you may hear a mitral regurgitation murmur. So patients with left atrial myxoma, sometimes you can hear a mitral regurgitation murmur also, but not usual. Okay, right? Yes, but
another thing can be that there
most
won't be
important you should have mentioned is that one most important thing you should have mentioned is that by changing the position of the patient, the murmur is not changing.
Murmur can change. Yes.
Here, the murmur is not changing at all. You auscultate in lying down and in the left lateral position. So, if the patient is having left atrial myxoma, the murmur can change with the position of the patient. Okay, right? Yes. Do you think that it is more triatriatum?
So cord triatrium is generally a congenital anomaly, so it is more often in younger age group.
Yeah, that can happen at later age group also. Do you get opening step?
No.
Opening step. So here is a loud opening step and also mitral regurgitation. You don't get mitral regurgitation in
cord
triatriatum. Okay, right. Yes. So all put together, you are thinking of that. Do you think that this is endomyocardial fibrosis?
No, sir, because in endomyocardial fibrosis, history-wise it can be there, but after examining the patient, we can definitely say that it is not endomyocardial fibrosis because we are hearing a lot of murmurs.
Yeah. You are hearing the murmur, opening step, all put together. It is not endomyocardial fibrosis. Okay. So you are sticking to the diagnosis rheumatic heart disease, most likely because all patients with mitral stenosis should be considered to be because there is no history of joint symptoms in childhood. Rheumatic heart disease, mitral stenosis, severe, mitral regurgitation, moderate, tricuspid regurgitation, at least moderate, pulmonary arterial hypertension, right heart failure, atrial fibrillation, and left heart failure by story. Clinically, you didn't get any basal crepitations to diagnose left heart failure. Okay, right. Now, investigations. Any student would like to discuss any other point?
Sir, can you please repeat why you said moderate MR and moderate tricuspid regurgitation?
Because how do you diagnose mitral regurgitation, severity of mitral regurgitation, Shivam? How can you diagnose severity of mitral regurgitation?
One is again LV hypertrophy. LV
hypertrophy. Can there be
LV enlargement?
LV enlargement. Cardiac enlargement. LV enlargement is one of the features of helps us to assess the significance of mitral regurgitation. 2,
Sir, hyperdynamic apex beat.
yeah, the forceful apex beat. Okay, right. Yes. 3,
Pulmonary hypertension again.
is it pulmonary hypertension a feature of mitral regurgitation? When can the patients of mitral regurgitation develop pulmonary arterial hypertension?
When the patient would be having left ventricular dysfunction.
Yeah, when the patient develops left heart failure, left ventricular dysfunction, then only they develop pulmonary arterial hypertension, or otherwise there should be associated mitral stenosis.
Yes.
Otherwise, there is no stagnation of blood in the left atrium, left atrial pressure will not go up, and these patients does not develop any pulmonary arterial hypertension. What are the other features to assess the severity of mitral regurgitation?
Sir, grading high grade murmur.
Murmur will not tell you. Of course, if the murmur is short, like for example, in a patient with mitral prolapse, where there is only a late systolic murmur, very often the mitral regurgitation is only mild. Pansystolic murmur, it cannot be, it can be mild, moderate, severe. All forms of mitral regurgitation can have a pansystolic murmur. In general, length of the murmur does not tell you about the severity of regurgitant lesions, but the length of the murmur will tell you about the severity of stenotic lesions. So mitral stenosis, aortic stenosis, the length of the murmur will tell you the severity of the stenotic lesions. But the
Soft
severity
S1
of
can be
lesions cannot be assessed by the length of the murmur.
soft S1 can be in severe mitral regurgitation.
Okay, pardon? Soft S1. All right. Soft S1 usually indicates poor LV function. So that may be associated with cardiomyopathy and all. But S1 may not tell you about the severity. Under this, look at the splitting of the second heart sound. How can the splitting of the second heart sound help you to assess the severity of mitral regurgitation?
Sir, in mitral regurgitation, there would be narrowing, there would be widened splitting of the second heart sound because A2 would come early because LV has now two chambers to empty into. So, since if the MR is severe, so more of the blood would go into the LA and less blood would go into the aorta. So, A2, well, aortic valve would close early, so A2 P2 gap would increase.
Yes. So the wide splitting of the second heart sound is a feature of to assess the severity of mitral regurgitation. Because in mitral regurgitation, the LV has got two outlets, one to the aorta and to the left atrium, and the ejection of the left ventricle is completed much earlier than that of the right ventricle, resulting in an early A2, and these patients can have wide variable split of the second heart sound. So these are the features by which you assess the severity and presence of complications. So take into consideration this patient. The complications we cannot give too much importance because atrial fibrillation can definitely occur with associated mitral stenosis. This patient is having apex beat which is down and out. The second sound is actually normally split. There is no wide splitting of the second heart sound. Third point is this patient is having severe mitral stenosis clinically, and hence a patient with severe mitral stenosis very unlikely to have severe mitral regurgitation. These patients can have moderate mitral regurgitation, but unlikely to have severe mitral regurgitation. So this patient has got few features to suggest significant mitral regurgitation as evidenced by enlargement of the cardiac enlargement. And two, the patient does not have wide splitting of the second heart sound, so the mitral regurgitation may not be very severe. So both put together, I would compromise by saying that this patient most likely has got moderate mitral regurgitation. Okay, right. Yes. Okay, right. Yes.
And sir,
yes.
regarding the TR?
Regarding?
Tricuspid regurgitation?
Here this patient is having few features to suggest significant tricuspid regurgitation as evidenced by good parasternal lift. There is a significant parasternal lift, a prominent V wave in the neck. These 2 points tell me that the patient has got a significant tricuspid regurgitation. So most likely at least moderate. So, and also the patient has developed right heart failure. All put together, I can definitely say that the patient is having moderate mitral regurgitation. And also right atrium is enlarged, evidence of right atrial enlargement. All put together, definitely moderate tricuspid regurgitation clinically. And even if somebody tells me that it is severe tricuspid regurgitation, I may even agree with that. But I will definitely go for moderate tricuspid regurgitation. So points for you to assess the tricuspid regurgitation are: 1, the parasternal lip; 2, the right atrial enlargement; 3, the presence of prominent V waves in the jugular venous pulsation. Length of the murmur will not tell you about the severity of tricuspid regurgitation. Okay, right. Go ahead, Shivam. Any ECG explain anything? No.
This is the ECG of the patient.
Okay.
In this, we can say that.
Before you go to ECG, on the basis of clinical findings, what are you expecting in the ECG?
In ECG, in this patient, we would be expecting one biventricular hypertrophy.
If it is possible, yes, you can get there because the patient has got evidence of LV enlargement as well as RV enlargement. Yes.
Another is atrial fibrillation.
Atrial fibrillation, very good.
And since the patient is having more, the main lesion is mitral stenosis, so axis would be mostly towards the right side.
Yeah, very good. So these are the few things that you expect: right axis deviation, atrial fibrillation. If there is evidence of biventricular hypertrophy, yes, biventricular involvement, then you can have electrocardiogram showing both the right ventricular and left ventricular hypertrophy pattern. But it's quite possible that the hypertrophy may partly get neutralized to each other, and you may not be able to get very prominent waves. Okay, right.
Yes.
Now let's look at the electrocardiogram.
So this is the electrocardiogram.
Okay.
Heart rate is approximately 80.
Okay.
Rhythm is irregular.
Okay.
Axis is right axis deviation.
Yes.
We are not able to appreciate the P waves.
The right axis deviation, you cannot say that. What is the axis in this patient?
So axis is almost 110 degree, 100 to 110.
It's about 90 only because the lead one is equiphasic, and so the axis should be around 90. So you cannot say right axis deviation. If you want, you can say the axis is towards the right.
Okay.
Okay, right. Yes.
P waves are not appreciable. Then
you can see flutter waves are seen actually. You can see flutter waves very prominently.
Flutter waves are visible in V1, V2.
No, in V1 and V2, you can see flutter waves. When you are seeing flutter waves in V1 and V2, what do you call this flutter as?
This is counterclockwise flutter.
It's an atypical flutter.
Atypical
flutter will be the flutter waves will be best seen in which leads?
2-3 AVF.
2-3 AVF. What is the significance of recognizing typical and atypical flutter?
So actually, typical flutter arises near the pulmonary veins, while atypical flutter can arise from any other location.
Typical flutter is not near the pulmonary veins. It is in the Cox triangle.
Around that.
It is in the Cox triangle, not in the region of the pulmonary veins. It is in the Cox triangle. The re-entry site is at the region of the Cox triangle, and typical flutter can be treated by radiofrequency ablation in the Cox triangle. While atypical flutter has got multiple re-entry sites in the atrium, maybe in the atrial septum, maybe in the right atrium, left atrium. So they can have multiple re-entry sites, and hence ablation is not practical. So atypical flutter atypical flutter patients are not amenable for radiofrequency ablation, while typical flutter patients are amenable for radiofrequency ablation, and the ablation can be done in the Cox triangle. Okay, right. Go ahead.
QRS complex, P wave is not, the P waves are flutter waves, then QRS complex is narrow. QT interval is not prolonged, then ST segment is not elevated, ST segment is normal. Then we can see the T waves. So T waves are not tall, but we can see inverted T waves in 2, lead 3, and AVF. And we can see that there is poor progression.
T wave is inverted in lead 3. I don't think it is inverted in lead 2 and all. Maybe flat, or it is very difficult to make a comment. AVF, okay, it may be flat, but lead 3, I agree there is some inversion of the T wave. That is not significant. Yes.
There is poor progression of the R waves from V1 to V stage. It is
Now, why did you say that? It is progressing. V1,
sir,
V2, V3, V4, it is more, V5, V6, it is definitely more. In order to look at the QRS complex, would you like to have a repeat electrocardiogram or repeat ECG taken?
pardon, sir?
Can you improve the voltage in this patient?
Sir, we can improve the voltage in this patient by decreasing the it is 10 mm per millivolt.
No. That is why you can only no. That is not the question. In this patient, where is the apex speed?
Down and out.
It is in the 7th intercostal space. So if you place the leads in the normal position, will you pick up the LV forces?
No, sir. No, sir.
So
We
how
have
can
to
you
place the lead more laterally.
No, not more laterally. One space down and more laterally. You have to take the electrocardiogram one space down and more laterally so that the LV forces are better picked up. So you should repeat the electrocardiogram in this patient with one space down so that one space down so that the LV forces can be better picked up. So here, when you take a normally placed leads, the LV forces will not be picked up because the apex beat is in the 7th intercostal space and 1 centimeter outside the midclavicular line. So you have to place the leads one space down and also go up to V7 if you want, so that the LV forces are well picked up. Okay, right, go ahead. Extra chest.
This is the chest X-ray. PA view of the patient.
Very poor X-ray. I don't know whether it's correct. Interpret. Okay, right? Yes. Tell me. Is the X-ray taken in a? It is an AP view, I think.
It's a PA.
Is it PA view? Looking at the rib cage, I get a feeling that it could be an AP view. AP view. Okay, go ahead.
Is the cardiomegaly is there?
Gross cardiomegaly, yes.
Gross cardiomegaly is there with the enlargement. The apex is RV type.
No, you can't make any comment. I think for RV type, the apex should be lifted up. And for LV type, it should go down, bend down. So here, there is no lifting nor dipping down. So I will not make a comment whether it's LV or RV type. I will say that it's a normal apex, or I will not make a comment whether the feature is not classical for LV or RV apex. But the only definite feature is, it seems that there is a significantly enlarged what chamber?
LA, left atrium.
Why did you say it's LA?
It is going in the direction of right border of the heart. So it can be RA or LA, but
how will you make out whether it's RA or LA? How will you make out whether it's RA enlargement or LA enlargement? The
RA enlargement will be more anterior.
Yes, more anterior, but how will you make out whether it's RA or LA enlargement? The LA shadow very rarely comes and touches the diaphragm, while RA straight will go and touch the diaphragm. So this X-ray shows an RA enlargement, not an LA enlargement. There is some evidence of an LA enlargement because the left dome of the left bronchus is actually pushed up. So I think there is some LA enlargement also. So LA and RA both are enlarged.
Yes.
Is there evidence of any heart failure? What are the X-ray features of left heart failure?
Sir, there is more vessels seen in the apical region.
Okay. Prominence of the upper lobe vessels. 1. The upper lobe veins become prominent. 2. When a question is asked, you should be able to say 1, 2, 3, 4, 5. 1 is upper lobe vessels prominent. 2.
Curly B lines.
Curly B lines. 3.
Hazy hilum, that is bat wing pattern.
Yes, before that you can say the ground glass appearance of the lung fields. 4.
Sir,
Peribronchial cuffing. Do you know
vessel,
about peribronchial cuffing?
sir, the vessels would be more in, vessels would be seen in peripheral 1/3 portion of the lung tube.
No. Peribronchial cuffing. What is peribronchial cuffing? There will be edema of the mucous membrane of the bronchi, which will result in a rounded white shadow around a bronchus, which is seen as the air in the bronchus is seen as dark shadow.
It's excess fluid,
And surrounding the dark shadow,
mucus buildup.
you
The
will
small
be able
area
to get the
excess.
fluid around the
Mucus buildup in the lung collapse.
bronch. And not the lung collapse, bronchus. Around the
Okay, sir.
bronchus, you can get white.
Sir.
Yes.
So
Yes.
I think there can be excess fluid in the mucus buildup and this in the small airway passage in where the lung cause the localized patches, or it can be.
No, I could not follow you. But I am trying to explain what is peribronchial cuffing.
Yes, sir. I mean, it's excess fluid, na sir. I mean, it's a radiological sign where there is excess fluid.
Yeah, it is a radiological sign where there is excess fluid.
lung collapse.
No,
Okay.
listen to me. Go on talking. So when both of us talk, then it is not clear to each other. You first listen to me, and then you can ask questions. So whenever there is a pulmonary congestion, that can result in edema of the mucous membrane of the bronchus and peribronchial edema, which will be seen as a white shadow surrounding a black shadow, which is the air-filled bronchus. That is known as a peribronchial cuffing. It is best seen in and around the hilum. What is your doubt? That is known
Thank
as
you,
a
sir. Thank you.
that is the peribronchial cuffing. Okay, then you can get the pulmonary edema. So whenever there is a pulmonary venous congestion, there can be 5 the radiological evidence. 1, upper lobe vessel prominence. 2, curly B lines. 3,
Ground glassing of the hilum.
ground glass appearance. 4, peribronchial cuffing. 5,
Sir, peripheral 1/3 area, parenchyma of the lung. In peripheral 1/3 parenchyma of the lung, the vessel would be visible.
the patient can go for frank pulmonary edema, which is actually even described as the bat wing sign, where the body of the bat is the heart and the wing is the 2 areas of the lung where there is evidence of pulmonary edema. So in this patient, is there evidence of pulmonary congestion?
No, sir.
No, not at all. The upper lobe vessels are not prominent, nothing. So that what is the reason?
Sir, actually, we are giving the patient furosemide, so it decreases the pulmonary edema.
Yeah, the patient is in severe right heart failure, and because of that, there is no pulmonary congestion. So this X-ray quite consistently goes with. So most likely, when this patient started developing right heart failure, secondary to with pulmonary with peripheral edema and all, I'm quite sure the paroxysmal nocturnal dyspnea might have come down. So if you had asked the patient whether your paroxysmal nocturnal dyspnea had come down when you started developing edema of the extremities, I'm sure the patient would have answered yes. So the upper lobe vessels are not prominent, indicating that this patient was got a left heart disease along with that right heart disease, and the right heart disease has resulted in less of pulmonary congestion. Okay, anything else? Any other investigation?
No.
Okay, so what is your diagnosis, final diagnosis?
So the final diagnosis is rheumatic heart disease.
Most likely rheumatic heart disease because of the history of mitral stenosis, yes?
Possibly severe mitral stenosis with moderate mitral regurgitation, with moderate tricuspid regurgitation, with pulmonary arterial hypertension.
I may think that tricuspid regurgitation may be severe because the right atrium is grossly enlarged. So after the X-ray, I think that the tricuspid regurgitation is severe, and that is why the upper lobe vessels are not prominent at all, in spite of significant or severe mitral stenosis. Okay, now the next investigation can be, so we'll have to, how can you confirm the diagnosis? By doing?
Echocardiogram.
Echocardiogram. Echocardiogram will tell you the the structural abnormality, we'll be able to make the correct diagnosis. Okay, I think you have discussed case reasonably well. I think you are a reasonably good student. That's my impression. By answering most of the questions you could answer, but you need some more polishing so that you can be a very good student.
Thank you, sir.
Okay.
It's an honor, sir, to present a case to you.
I think you did very well. I think I'm pleased because you could answer most of the questions, and I don't expect any student to answer 100% of the questions, but you could answer most of it. And your descriptions of the clinical findings can be made a little more crisp and short, rather than making it very elaborate. Make it crisp and short and convey the total sense. Okay, right. Where is Balaji? Balaji, are you around?
So I have one doubt.
Yeah.
Sir, why there is systolic separation of the mitral leaflets can be seen in the echocardiography of RHD?
Why? That is because
Yes,
the suppression during which phase? Diastolic phase.
Why the systolic separation of the mitral leaflets can be seen in the echocardiography of the RHD?
In systolic phase.
Yes, sir.
Yeah,
Why?
okay. Yeah. That is one of the reasons is because of the in mitral stenosis, the posterior leaflet is fixed. Two. Why do the two leaflets opposite to each other? In systole, why do they opposite to each other? Because they move back and come together and then they are opposed. In mitral stenosis, what happens? What happens to the chordae? What happens to the papillary muscle? Doctor, what is your name? Who asked this doubt? What is your name? Doctor, what is your name? You asked this doubt. What is your name?
So he has probably gone offline.
So he has asked a doubt and he has gone offline.
Probably his net connection is wavering.
Okay. So,
sir, I had a doubt.
No, I will explain this. So patients with mitral stenosis, rheumatic heart disease can shorten the chordae. Their papillary muscle can get fibrosed. That will result in less of moving coming together and getting opposed. It is because of the shortened chordae that the subvalvular pathology, which will result in the lack of coaptation of the leaflets, resulting in significant mitral regurgitation. It is because of the subvalvular pathology. And of course, the valve can also get shortened. It can be fibrosed. It can become shorter. And the total valve pathology will result in lack of apposition. Okay, yes. What is your doubt?
Sir, why do we take, what happens exactly after a long cycle in atrial fibrillation? I did not understand that part.
See, whenever if there is a long cycle, the long cycle is due to long what phase? Is it due to long systolic phase or due to a long diastolic phase?
So long diastolic phase.
The long diastolic phase. When there is a long diastolic phase in a patient with mitral stenosis, what happens to left atrium?
It gets engorged.
No, it gets decompressed because during long diastolic phase, the mitral valve is open, so the blood can flow from left atrium to left ventricle. So in a long diastolic phase, the left atrium is more decompressed than when there is a short diastolic phase. Is that clear to you?
Yes, sir.
So when there is a long diastolic phase, left atrium is decompressed, then what will happen to left atrial pressure?
It will decrease.
Decrease. So when the left atrial pressure decreases, what will happen to A2OS interval?
It will increase.
It will be wider. So
Yes.
if you find that in a patient with atrial fibrillation, in a cycle following the long cycle, if the A2OS interval is still close, that obviously means there is severe mitral stenosis.
Okay, sir.
Did you get the point?
Yes, sir.
Yes. Any other doubt? If you have got any doubt about mitral stenosis, you can ask now.
Sir, one question, sir.
Yes.
Sir, beyond what degree of pulmonary arterial hypertension does someone actually develop a right ventricular failure? Like pH can be either mild, moderate, or severe. So is there any such dictum that only after moderate or severe does the patient develop RV failure, or with persistent mild pH also the patient can develop RV failure?
See, actually, in a patient with rheumatic heart disease, there are many things. One, the rheumatic heart disease can affect the right ventricle also. It's because the heart is a sensation and the left ventricle is affected, right ventricle also can be affected. Second, the right RV failure is depending upon the rapidity with which pulmonary arterial hypertension develops. If the pulmonary arterial hypertension develops over a long period, the right ventricle has got enough time to adapt, and that will result in less severe right heart failure. If the right ventricle of the pulmonary arterial hypertension occurs over a shorter period, that will put a big strain on the right ventricle. Right ventricle dilates. When the right ventricle dilates, that will result in dilatation of the tricuspid valve. That will result in tricuspid regurgitation. So the development of pulmonary, the speed with which pulmonary arterial hypertension develops decides the degree of RV failure. So you cannot tell about the severity of pulmonary arterial hypertension. That is important, but on top of that, the rapidity with which pulmonary arterial hypertension develops also is important.
Thank you, sir.
Any other doubts?
So would you like to conclude the session now?
I'm ready to conclude. If there are no more questions to be asked, I think the session can be concluded.
Shivam sir, are there any doubts from your side?
No, ma'am.
Shivam.
Okay, then we will.
Okay, may I conclude the session?
Yeah, thank you.
Yeah.
And if you want any, Shivam, you contact Balaji and let me know whether you want a class next week, and if so, whether who is presenting the case also. Okay.
Thank you very much.
Sure, sir. That can be arranged, sir.
Okay, right. Okay, right.
It was indeed a comprehensive clinical class, and the discussion was very useful to us. Thank you so much, Rajan sir, for teaching and guiding us. We are ever grateful to you, and we look forward to all your future sessions with White Army. It was a great effort by our presenter, Dr. Shivam Arora sir. We could learn a lot because of your well-prepared presentation. We also thank all the participants who were actively involved in the session. Thank you one and all, and I hope you have a good evening.
Now, may I know what is your name?
Yes, sir.
What is your name?
Sir, my name is Nandini, sir.
Nandini.
Yes, sir.
And what is your capacity?
Sir, I am a fourth-year medical student from BGS Gyms, Bangalore, sir.
Oh, okay. You're a fourth-year medical student. Okay.
Yes, sir.
Fourth-year medical student, some of these discussions may be slightly difficult.
Yes,
but,
sir.
Because fourth-year medical student has got to study not only medicine, surgery, gynecology, this, everything. And so some of these things may be difficult, but gradually you may be able to comprehend a lot of these things.
Yes,
okay.
sir.
Okay.
Thank you so much, sir. Thank you so much. It was an amazing class.
Okay, bye. Okay, right, bye.
Bye. Good night, sir.
Good night.
Thank you, sir.